So really pleased to welcome everybody. My name's Helen Chatterjee. I'm the Programme Director for the research programme Mobilising Community Assets to Tackle Health Inequalities, which is a UK-wide research programme funded by UK Research and Innovation in partnership with the National Centre for Creative Health. And today we're really excited to launch a piece of research that we've been doing with Gloucestershire Integrated Care Board. And we're really pleased to welcome Hannah Gorf, who's the Senior Programmes Manager from NHS Gloucestershire as part of that ICS, and Jane Hearst, who is the Research and Policy Manager at the National Centre for Creative Health and a researcher on the Mobilising Community Assets programme. And so a very warm welcome to you. Just a little bit of housekeeping that I've already mentioned is to please keep yourselves on mute throughout the presentations. We're going to hear two presentations from Hannah and then Jane. And then we're going to open up the floor to some questions. So please feel free to save up your questions. And what I'll then ask you to do is raise your hands and I will whiz around the virtual room and ask you to speak your questions out straight to our speakers, if that sounds okay. And the report that we're launching today, we will post in the chat the link to that report once our speakers have given us a little bit of background and context about the learning that we've done. We are recording today and we will make that recording available on our NCCH Mobilising website once our session is finished today, so you will have access to that. And I think that's all my housekeeping. So without further ado, I'm going to give a very warm welcome to Hannah Gorf from NHS Gloucestershire and thank her for her great collaboration on this project. And I think you'll realise why it's so exciting and why we're so excited about this piece of research. So over to you, Hannah.
Hello, thank you, Helen. Yeah, so my name's Hannah Gorf. I work for NHS Gloucestershire Integrated Care Board as a Senior Programme Manager in a team called Healthy Communities and Individuals. That team has a focus on prevention, self-care, and work with the voluntary and community sector. And I lead on a portfolio that includes social prescribing, creative health, and volunteering. So I just think this is really important that we keep striving for the arts and health. Creative health is a nice to have, not a nice to have, it's a need to have. So I just wanted to share with you some comments that colleagues of mine have made to me in the past. This is like a few years ago. People have come up to me and said, "Oh, Hannah, you're so lucky. You've got such a nice fluffy role. You know, like in the NHS, it's so fluffy and it's so nice. You know, I'm so jealous of you to be able to do just nice things all the time." And other people, commissioners, have said to me, "Your work shouldn't be funded by the NHS. You know, like it's nice what you do, but we shouldn't be paying for it." And so I just wanted to share that because it's not that this came out of thin air around how we've embedded creative health in the integrated care system in Gloucestershire. We fought for it, and by we, people with lived experience have fought for this, and artists have fought for this, and creative health providers have fought for it. But what did we do? We came together. You know, so we fought together. And I think that was the really important part, that we found our allies. And then we fought throughout the system. So finding your allies all the way through the system in your hospital trust, in your community trust, in your art sector. And then we surfaced the evidence. So there's so much at the time, you know, like 5-6 years ago, there was lots of evidence, you know, international evidence, national evidence. And so we were all saying to our colleagues, you know, but the evidence is here. And including Artlift. So if none of you have ever heard of them, you know, Artlift is a local creative health provider who's been evidencing this for a long time in partnership with universities, with academic partners, but still the system needed more. You know, that wasn't enough. It was like, yeah, I don't know whether they even read all the things I sent them, but, you know, so we started with, okay, so around the evidence then, what is it that people need and want? And we started with one of our core principles of creative health in Gloucestershire, which is around co-production. So if we wanted it to land, then we needed to apply that same principle of involving people from the outset. And we needed to stay core to our values. because if we don't measure what we value, we risk just valuing what we measure. So what matter? So we got together with people with lived experience, clinicians, commissioners, because it can't just be me as a gatekeeper in, one person in the NHS in Gloucestershire. You have to be able to spread it, and make sure that you spread those allies across, and you keep building your number of allies as well. So what we found out was like what matters to people with lived experience was mainly not to have their experiences tainted, and I just use their words, by questionnaires asking how rubbish they're feeling. And what mattered to clinicians, well, that was about who are the people that are doing this work, that are like providing these creative health programs, and will this be of something of benefit that I can offer my patients, and how will I know that like what I'm offering them is any good? And commissioners wanted all the like money value stats around health utilization and validated outcome measures, mainly for use in business cases. And the creative health facilitators wanted something that was meaningful for people, that doesn't compromise the creative activity, and that their relationship with the people that they were supporting through the programs. So you start with we always start with where we want to end. So what are we trying to achieve, and how will we know we've achieved it? But for everyone to get what they want, that's hard. And so sometimes we need to push back. Sometimes people would say, I want to do, and I'll give you an example. There was a Children Young People's Commissioner that said, I definitely want to do WEMWEBs and short WEMWEBs, which is the Warwick Edinburgh Mental Wellbeing Scale, for the Children Young People's mental health creative health programs. So we used it at the time. We did actually go with it. And then I met with all the children, young people who had been on the program via Zoom, because this was like a COVID time. And I met all of their pets on this Zoom call, because they all showed me their pets. And then I got to talking to them about the program and what they liked about it. And I did ask about the questionnaire. You were asked to fill in a questionnaire, and they all turned around and said, yeah, we went down the middle. And I said, pardon? They went, yeah, we're really used to doing these types of questionnaires, but they're boring. We don't understand it. So we literally just circle everything down the middle. So we could go back to those commissioners and say, you're not getting meaningful data anyway. So therefore, we move to goals-based outcomes instead. This is just one example of how we can ensure there's personalised care being offered, but also with a statistical analysis that can be attached to it that satisfies the commissioners, who then will embed the creative health programs into their pathways, into their NHS commissioned pathways, which is what's happened. So in Gloucestershire, the Children and Young People's Mental Health Pathway has creative health offers in it, but we started from one place, and we've now gone through this journey to the place we're in now. And we also have to show people the possibilities of supporting a range of health conditions, because we are the NHS and they love seeing and talking about health conditions. And again, that can speak to health audiences then around, maybe you don't think this is something for people with epilepsy, but let us show you that it is. And to show commissioners that we're supporting people who may not be accessing their other traditional health services. So this is our health inequalities data, showing that actually creative health programs in the main are supporting people from our most deprived areas using the indices of multiple deprivation, and from racially marginalised groups in the county. But I suppose then, just to talk about the how, a bit about the how. So there is my role in NHS Gloucestershire. So I'm what's called apparently a boundary spanner, which is that I've worked in the voluntary and community sector, and I've worked in the public sector, and therefore I can speak multiple languages, and I have an understanding of the strengths, opportunities, weaknesses, and risks, and can work strategically but support operationalization, if that's a word. So that the ability to move the strategic to actual operations. So I'm in meetings, I don't take my role for granted at all because I'm in all these meetings all the time with health colleagues. Whenever they're talking about something, I can say, have you thought about creative health? Let's think about creative health. We could do something with creative health and keep on showing them the evidence, talking about creative health, sharing videos. Whenever we get good videos come through, I share it really widely with all of my colleagues. There's this great song that the children, young people with physical health, long-term physical health conditions have written and produced with one of our creative health providers called The Music Works. And it starts, the first line is fighting with the NHS to get heard. And the first people I sent that to was to my chair and to my chief exec to say, this is how people are feeling. This is how these young people are feeling. So and then they listened to it. They got back to me, but I have that position by working in their organization to be able to send that to them and be able to know that they'll open my email, I guess. Though I'm sure they didn't open all of my emails. And then also, we've got the Creative Health Consortium in Gloucestershire. So we've got a creative health sector that's got strong skills, knowledge and experience, which I'm sure everywhere across the country has. But it means that they're working collectively whilst retaining their individuality. So the NHS gave them support to come together. So we gave them financial support to come together. We funded a program manager who, and we funded their time to meet and decide what are our collective strategic goals here, and then how can we work together, and at the end of the day, their trustees had to agree for them to come together and spend that time doing that. So that had to be a really good reason for them to spend their time on that. But the consortium are a very attractive commissioning option, because even if you're just commissioning one organisation for, say, children, young people's mental health programs, you get the knowledge of all of them. You know that they're all working together, they're talking with each other. If a child gets referred to one program and actually really it should be for their physical health condition, then that can all seamlessly happen, for example. So it helps with the data being pooled. So they pool their data and then send it to us together rather than them individually sending us all their data, which is a big efficiency for them and us. Which brings us on to the role of the wider NHS, and the first one being business intelligence. So we've had the support of business intelligence colleagues, and they've been pivotal in developing our creative health dashboard. So they put all their quantitative data into a place that easily shows the data from where the referrals come from to the localities of where the people being supported live. It's one-stop shop place to see all the outcome measures and also health utilization data, which in theory then you can turn into cash. So if we believe, like if the health utilization goes down and we can say, oh, creative health has contributed to that, then each GP appointment equates to X amount of money. Each admission is X amount of money. And then plus we can overlay our data. So for example, in one of the earlier slides, I showed that health inequalities data. That's because we can overlay it. And that business intelligence person has met with the consortium members on numerous times to talk to them about how to put that data onto the system, to get the dashboard to show like good quality data, to make sure it's really good quality. But that business intelligence colleague, it means that she's really come out and understood what the creative health programs are about and who they're supporting and what they do, to again get her buy-in and their buy-in to say, this is something that I will talk to my manager about and say, this, I need to spend time on this. I need to put a lot of energy and resource into this. And so you just need to, I suppose my final things are about winning over commissioners and clinicians in the wider NHS. So what we do in Gloucestershire is we first tug at the heart. So we share some really good qualitative data, videos, songs. We invite people to come and come out and see the programmes in action, to really tug at their hearts. And then we use the statistics to blow their minds. So we're showing them the art of the possible and then opening up their world to the power of creative health. That's me. Thank you.
Absolutely awesome. Thank you very much, Hannah. I love you describing yourself as a boundary spanner, and that really clearly articulates how important that role is. So thank you, and thank you for collaborating with us on this project. So without further ado, we're going to next hear from Jane from the National Centre for Creative Health and a researcher at University College London. And Jane is going to talk through the research that we've been undertaking with colleagues across Gloucestershire, including Hannah and Felicity and her team. So over to you, Jane.
Hello. So the report that we created is called Embedding Creative Health in Integrated Care Systems, Insights from Gloucestershire, and it is now available on the NCCH website. It was part of our deep dives, which is a type of research that we do in the Mobilising Community Assets research programme, which looks at systems and how they have integrated creative health into those systems so that we can learn and share that learning nationally. So we look to map creative health and or community asset ecosystems within the health system, identifying pathways, key roles and structures that promote or enable integration with a particular focus on addressing health inequalities. We use qualitative methods to explore the barriers and enablers to integrating community assets and identify the kinds of information, data and evidence that are required by health systems to integrate community assets in a sustainable way. So with a particular focus on funding and commissioning and demonstrating the economic case for integrating community assets. In this deep dive, which is the first that we've published, is the information, how we collected it was through interviews primarily with past and present health leaders from the Integrated Care Board, along with members of the Creative Health Consortium. We have followed up with some freedom of information requests about spending. We looked at ICB reports and a little bit of the academic studies that have come out from the likes of Artlift, as Hannah shared, about the consortium, to be able to triangulate data and make sure that we were getting the most accurate accounts. I then was turning things into data visualizations to try and make that information as accessible as possible for readers, and then being able to take that back to people that were interviewed and go, is this correct? And then followed that up with thematic analysis of anything that was really useful in those stories, and identifying key enablers that could be placed on enablers pages. The data was mapped against time, health disciplines and systems, in-depth case studies, then about the data dashboard and the creation of the consortium. We followed up with discussions with participants in case anything was could be adjusted in the way that that was presented in the report, and fill in any gaps that they identified. So firstly, one of the insights, we created this journey map. So moving from the early 2000s, when this work started kind of bubbling up in a GP through a single champion, and following that process to see what kind of stakeholders joined and helped along the way. And we see this merging of new stakeholders helping different bids along the way, the movement from creative health providers as just individual organisations to working both as organisations and as part of the consortium, and then bringing in these support roles like Hannah's role, which are really instrumental for helping to support that greater evidence collection and translation of information along the way. And then all of that is supplemented with quotes from the interview, so you get a taste of what that journey looked like. And what that showed us is that the right stakeholders shape along with the system over time. So there isn't one right way of doing everything. We are showing what worked in Gloucestershire so that they can share ideas and learning, but these all adapt to different integrated care systems based on where you are at the time that you're trying to start your creative health journey. So part of that journey, we looked at how key champions are for delivering that scalable proof of concept and identifying opportunities for spread and adoption. So in this context, Simon Offer was really key for bringing it into his GP surgery, that spread as an arts on prescription to a wider range of 15 sites. And eventually, as you'll see in one of the maps, it's now spread to every GP surgery, and primary care network has referrals from those areas. Showcasing success stories with health reports was really important along the way to keep getting new stakeholders to be aware of the work. They started with external funding opportunities, which enabled test and learn pilots to be brought in. So this is that lower risk, high reward kind of starting point, which can then be used as to contribute to a business case of having that mainstream NHS funding. Co-delivering new services around local assets was really important. So instead of going, here is the data nationally, and so we're going to try and find a way of making this work without creative health providers that specialize in those areas. There was a focus on, here's what we've got locally, here are the strengths, how can we build new provisions around our local needs, and co-develop things that we can trial and then take the things that work and mainstream them. Training then was really important. So bringing artistic facilitators up to the standards of what is necessary in the NHS through things like asthma training, making them feel really confident in the provisions that they're able to provide. And then the development of an NHS business case came more recently, allowing for a more sustained funding agreement and that long-term planning from the creative health providers. One of the things that I thought was really interesting that came from this is the route of referrals. We often hear about how primary care and social providers can refer, whereas in the Gloucestershire system, because it's coming from their clinical pathways in secondary care, that's one of the system places where those referrals are coming from. We've also got this really key referral route through self-referrals and community. The third insight that I thought was really interesting is embedding this kind of public health approach, which is upstream, preventative, into clinical work streams. So not relying on the NHS and local authorities as working separately and having separate tasks, but seeing prevention as a shared responsibility, which allows for more possibilities to happen. And this is really conducive of creative health style provisions. We also heard about the networked clinical program approach. So two things in that was making sure that everyone from across different parts of the NHS system were working collaboratively for different types of clinical issues, and then being able to look at the local populations of what the needs were that people in the systems needed to focus on to be able to uplift and respond to health inequalities. This was really essential for promoting that regular partnership working across the system, and co-design was a really key part of working around local and community, local creative and community assets. NHS governance, we could see in this diagram that we created from the system is hierarchical. It has stages going from, in primary care, in this example, localities to primary care networks to GP surgeries to doctors, and you have this spreading of information, and that worked really well with the way that the NHS governance works. So what I thought was interesting about the Creative Health Consortium is it creates one of these webs into the organisations that makes it easier for services to be commissioned while still keeping the more flat hierarchies that we expect in creative health. So kind of working through the strengths of both sides of those systems. A sixth insight in terms of the development of the consortium was how it required really strong relationships. What came through from the consortium members in their interviews was that they had to have really somewhat difficult and honest communication in those early days of whether this was the right decision for them, what it would realistically mean for all of their organizations, the pros and the cons. And having those established long-term relationships meant that the communication could be more honest, and it was a safe place to have those communications, which were ultimately instrumental for being able to create a strong consortium that would be able to last in that structure. Insight number 7. Core funded coordination roles were really pivotal. So roles like Hannah's and roles like Felicity's, who it was the business intelligence analyst, that created really consistent communication and harmonization between the ICB and creative health providers, that kind of ongoing development of their systems and processes so that both sides were getting some of their needs met in their relationship. And then insight number 8 was developing the minimum data set, which Hannah has talked about. So using NHS numbers was a really important part of that, because it meant that the creative health data could be linked to NHS data more broadly, and create those insights that Hannah has talked about. Here are some of the visuals from the creative health data dashboard that appear within the report to give you an idea of the way that that data then gets visualized for their team. And that is me for now. The rest of the insights will be talked about a bit more broadly in the report, which I'm sure Helen will give us a link to.
Brilliant stuff. Thank you, Jane. I mean, and I hope you can see from that that collaboration with a whole series of colleagues across Gloucestershire, particularly Hannah and her team, and obviously the Creative Health Consortium, how insightful that has been to understanding that journey that Gloucestershire have been through. Over, I think it's fair to say, Hannah, a fair period of time that system has evolved, but that the really close involvement and the partnership, and how necessary it is to have that time and that evolution, but having that senior leadership really important. So we just want to say again a huge thank you to Hannah and her colleagues and the whole of the Creative Health Consortium for sharing all of your brilliant work that you've been doing, and giving us the privilege and the pleasure to come and learn from you and to be able to share it with you guys. And I will put a link in the chat. Whilst I do that, I will then invite you all to start thinking about your questions. We've got loads of time for questions. So I will invite you to just raise your hand, and you can do that just if you go to React, which is at the bottom of your screen, which is a sort of little heart, and there's a little raise hand button. And what I will do is look across my screens, waiting for some brilliant questions. I've got loads of questions, but I really want to invite members of our audience to ask questions. I can see one question already. I don't have Bright Sparks Arts Coordinator. I don't have your name, but it would be great if you want to turn your mic off and ask your question. And welcome. Nice to see you.
Hi, Helen. It's lovely to meet you finally. I've seen your name written on various articles and books that I've looked at over the years. Great to meet you, and thanks for those amazing presentations. It's really, really fascinating to hear. I am Sally Varnham. I am the Bright Sparks Business Development Officer person, but also I work with Leicester's Hospitals as their Creative Health and Heritage Manager. And I know Jane really well from her role over here. So I was just listening with much interest in how the Creative Health Consortium was formed originally, and I just wondered if there was a little bit more information on some of the kind of barriers to how that might have happened, and how those might have been overcome in the earlier days, because this is something that we're bringing together at the moment in Leicester and Leicestershire. So that would be really helpful. Thank you.
So one of the things that we talk about in the report is the lead provider model, which is what was chosen by the consortium. So it goes through all the different kind of processes of how to do that, one of which is a consortium agreement. What we found in Gloucestershire is that it's quite a targeted the people that are in the consortium. So it's a bit different to bigger networks that we're seeing elsewhere, which might be the case for Leicester. So I imagine there'll be some differences in the way that they operate. I guess the big insights that we were seeing from them is they were working in the system already together. So there's 5 key organisations in the Gloucestershire Consortium. So they had those established relationships over time. The timeline that I showed at the beginning of that presentation, that's a 20-year timeline of embedding creative health into the system. And one of the reasons why they created a consortium was to help that flow of money, but also to create that business case for creative health more broadly. So it was led by some of the guidance of Hannah of how that would enable future process, and then deciding whether the way that would impact them in terms of the extra data that they would have to collect, and the way that they would govern that would be appropriate to them. So I don't know if Hannah would like to comment more broadly from the kind of lived experience perspective.
Thanks. Yeah, so initially they were they're 6 organisations now, because they've just welcomed their first like non-founding member as a creative health provider, but they were chosen by the NHS, because exactly what Jane said. Basically, it was who's on our patch, what are they doing, and actually what are our needs as well, and then where do they align strategically. An example of that being Mindsong, are a local creative health provider who were doing work with people with dementia, singing like music therapy for people with dementia, and we asked them if they would do it for people with respiratory conditions. And then the NHS upskilled the artist facilitator, the musical leads, the vocal leads in respiratory conditions and exercises, etc. So therefore, because those organisations didn't necessarily choose one another, like it was the NHS that chose them, they would admit it was painful, to begin with. But they all say as well, though, they were all working with each other in some way, shape or form. Like Jane said, they were, because they were all part of the system in some way. They'd all they did all know each other personally, like as individuals, in the world of creative health and the art sector in Gloucestershire. I think that really helped with those honest conversations, because some of them have known each other for 20, 30 years. And so they were able to call each other out a little bit if they felt someone wasn't behaving in a way that they would like to see. But we did do a lot of hold it. I would say that I held quite a lot of emotion. I think like a lot of the Creative Health Consortium members have cried on to me, about things. And so you have to have those really trusting relationships is what I would say. Yeah.
I hope that answers your question, and yeah, once again, that really beautifully articulates those special relationships. I've got a question, but I'm going to hold off, but which is about who's in the consortium and who's not. And just to say, if there are any creatives from Gloucestershire here, we'd love to hear from you, particularly if you're part of the Creative Health Consortium, what kind of work you're doing, and perhaps your own experiences. But if there are other creatives from Gloucestershire, we'd love to hear from you as well. Next question is from, I can see Marion has got a name up, and there's also a question in chat, which I can come to in a minute. Marion, over to you.
Hello, and apologies from moving from sort of relational value, as we were just talking about, and community building, to ICB metrics. I feel I'm losing my soul as I go that way, but I run the special interest group Creative Health for Nurses. I've been in the NHS forever, and the dissonance that I'm having at the moment is the measures that are being used for, or developed for, the impact on neighbourhood health approaches are of the medical model and reductive, and they don't seem to be receptive yet to actually putting this way into that high level lexicon and matrix to actually make sure that when that comes out, ICBs are actually able to commission creative health. And I just wonder, with the evidence base that we've got, it is relational and emancipatory and all of these things, but the link to getting people off benefits or stopping GP the activation measures are great, but how can we get into the maths of it so that social enterprises can be commissioned to do this, or rather than what I see happening?
Really good question. Hannah, you're going to have a go.
Yeah, I understand. And it is what I was talking about, I suppose, about everyone's got what they want the data to tell them and the different types of data. Because when I say data, I mean all the qualitative data as well as the quantitative data. And so that's why I guess in Gloucestershire we developed, the NHS said we want to develop this dashboard because it collects NHS number, which means that we can talk about health utilisation, which means we can turn it into cash. But that's not to say that's more important than the qualitative data. But that is the hard one to turn. What we've done in Gloucestershire, we funded the University of Gloucestershire School of Psychology to take all of the qualitative data that the Creative Health Consortium has. So that includes artist reflective logs, case studies, participant feedback, and they're doing an analysis of that data to be able to give us like statistically significant type data around. So actually looking at this, it shows you that social isolation and loneliness is like being combated, being tackled by this, because I work in the NHS, so I hear you 100%, Mariam, because I'm in that every day and I'm hearing the stats every day, and that's what people want to talk about. I'm always trying to think of ways that we can not compromise the experience, the creative health providers. And by the way, one of the creative health, I'll never forget, one of them turned around to me and said, I don't feel like a musician anymore, like because you're turning me into something else. And so we have to balance that all the time. And so it's like, what can I do to take that off you then? Like, what do you so constantly having those conversations. But I would say that because neighbourhood health is such a new concept, it's sort of new, but not new. It's all blurry. What do people mean by neighbourhood health? NHS England have a statement on what they think it is, but locally it will be determined. So I'm always trying to think of how the Creative Health Consortium members can have their voice in strategic positions. So they now have a place on our VCSE Strategic Partnership Board, which then has a place on our Health and Wellbeing Partnership, because it's just about raising those voices, but again, as a collective. So I remember having a conversation with some of the consortium members when I called them the voluntary sector, and they said, we're not the voluntary sector, we're the arts sector. And I said, but sometimes I think that you have to go with the voluntary sector if that's who's being heard, like you have to play a bit strategically in that space. And it's a bit like some people call creative health social prescribing. So some people will say social prescribing and then they'll start talking and I'll think, oh, they mean creative health. So it's how you can find those strands to add it to, where people are, if they're saying they're going to invest in social prescribing, brilliant. So you mean this as well. So how are we going to how are you embedding this with it? I didn't really answer your question because it's so local. Like each local area will be taking this in their direction.
Yeah, it's the acceptable measures for social return on investment, and how can we marry those quantitative measures that are fiscal up with by still holding the concept of arts, is more than just making people get back to work. And that's my dilemma.
Yeah, I think you just have to keep surfacing stories. Somehow you just have to keep surfacing the stories that aren't about getting people back to work, but about hope. and like, because that, is what I would say, because that's where you get people in the heart. You have to really get the people in the heart. I did loads of Googling of my execs before I joined, to find out what they were interested in. And you can find out quite a lot about people online.
Yeah, thank you. Thank you.
Jane, was there anything you wanted to add in there? I think it's such an important question, Marion.
I think one of the roles that I'd like NCCH to play in this is thinking about how the 10-year plan's movement towards digital progression might help us in the way that we evidence creative health. So one version of that, which kind of builds on the strengths of the Gloucestershire experience, is they've shown us that linking that NHS number or NHS data to data points is really important. So is there kind of quick win solutions of how we can get it on a patient's record that they've been to a creative health provision? So it might be scanning a QR code as you enter a creative health provision, and then all that data is technically there that can be analysed in the background for people that are ready to. Ways that we're not fatiguing our participants with feedback that doesn't feel like it's capturing them, but is still capturing that they are going to a creative health provision, and this is what has shifted afterwards. And then I think there is opportunities in digital that bring the strength of our qualitative evidence to a place where we can maybe turn it into quantitative data. So for example, there's a great creative health provider called Noise Solution who provide mental health artistic services for young people. And they record videos after each session where the young person will just talk through the session, how it felt for them, where they're at. And this is just a consistent thing that's a self-reflective experience for the people involved, which means you've got this kind of diary of how they've progressed over time, rather than measuring against strict well-being measures that may or may not resonate with them. And you've got tools that are standardized in research like NVivo, which are now getting safeguarded AI functions, like being able to put in those transcripts where you can then ask it to see how much negative things were talked about or how many positive things were talked about. And so if you had this huge qualitative data sets that you can put into those more safeguarded AI functions, I think that will be a great way of going. We don't need to be sticking to these measures per se that are predetermined, that don't resonate with participants, but we can track that there has been a movement towards some kind of positive outcome over time through this in-depth analysis of qualitative data that can be turned into numbers or things that maybe resonate with health systems a bit more closely.
Sorry, just to say that's a bit like what we're doing, like with the School of Psychology, because the goals-based outcomes that I mentioned for the children, young people, they actually get given, they can have it either digitally or they can have it as a thing to hold, like a journal, and then they come up with their goals, up to 3 goals that they want to achieve, and then they they use it all. And then at the end, they get asked, would you ever be okay with sharing this, with commissioners, etc. So I'm allowed to see the ones that say yes. And a lot of the goals are things like, I'd quite like to be able to come without my mum having to stay for the session, for example. So they're all goals that are so about that person. But when you share that with people in the NHS, that can be quite powerful. As well. But like Jane says, that's why we're handing some of this over to say, now turn this into not just one story that I can share, but something like that I can really showcase in the system.
Yeah, I mean, I think it's such an important question and point that you've made, Marion, and I guess the other aspects of the learning that we're finding from the mobilising programme and the work that NCCH and others are doing, including NASP, for example, around, there's lots of increasing discussion around the ideas of what would a minimum data set look like if we had a national minimum data set for community-based non-clinical interventions. What would that look like? And that's such a difference from, even 5 years ago, where
Yeah.
there was very little interest in that, isn't there? So I think that is positive. And the agreeing what is in that minimum data set, whether it's around patient activation or and how you encapsulate all of that, I think is an ongoing discussion. But and it's something that's certainly within the group we're really interested in. So watch this space. There'll definitely be more. That's really what's fed into us doing this work with individual integrated care systems, because a lot of those systems do want to go through the processes that Gloucestershire has gone through and think about things like a data dashboard, linking up participation data with health utilisation data to understand the impact on outcomes. So yeah, it's really important work. Thanks for your question, Marion. Please do keep your questions coming. I can see a question from Claire in the chat. Claire, I don't know if you want to ask your question out loud or you want me to ask it. If you don't shout up, I will read it out. So what Claire says is, how does the work map alongside devolution and local authority restructuring? I don't know who wants to think about devolution and local authority restructuring. Thinking also about ICS restructuring, Hannah.
Yeah, there's a lot of change coming to statutory sector, both in the integrated care boards and in local government, which can be really unsettling, I'm sure, for people in the art sector, the voluntary and community sector, where you've built those trusting relationships, and then suddenly individuals might not be there anymore, and then roles might not be there anymore either. Hence why it's really important that you spread that knowledge across the whole system. So, I spent quite a lot of my time talking to the hospital trusts, the community trusts, because it can't just be in the commissioning space. It has to be in the the clinician space as well, because they can fight for things. They can say that really worked for the people. I've actually had consultants write letters to commissioners to say, I've seen this person for like a year, 2 years. They've deteriorated. I referred them to Mindsong, and now that's the biggest change, the biggest impact that they've had. And they send those letters, so, and I'm like, yes, because it's not just me, and that's what you need. So with regard, I think Gloucestershire might be a bit unique because we've got a really close relationship with our public health team, and it was public health that initially started the journey of this when public health was in the NHS. But since then, I talk to my public health colleagues, but it's funded by the NHS and embedded in the NHS pathways. And so that devolution isn't as it won't impact us, I don't think, in Gloucestershire as much as potentially elsewhere, where there's that more tangible link. I'm not helpful, sorry.
I think this will be something that will pop up a bit more in one of our next deep dives, because we're hoping to do one in Birmingham, potentially spreading that to Black Country. And Birmingham, will be focusing more on their public health side of things in local authority. But obviously their ICBs are merging, and they've got their combined authority starting to have a more of a presence in the creative health as well. So we'll be looking at how they work separately. So as Black Country has also been doing some great creative health work in their local authority, how that bringing together, so recording both the past and then starting to work with them of how that will impact their next stages. So watch this space, I guess, is my answer to that one.
Thanks, Jane. I've got Riyadh on my list, but also, first of all, Olivia. Olivia, wonderful to have you with us. We can't see you. It sounds like you're having tech issues.
Can you see me now?
We can hear you.
You can hear
Go
me.
ahead. Go ahead and ask your
Hi,
question.
nice to see you, Helen.
Lovely to see you, and welcome.
Thank you. Yeah, I just
Do you want to say where you're from, Olivia?
Hey. Oh yeah. So my name's Olivia. I'm Worcestershire Public Health, and I've recently completed the Creative Health Mask, which Helen set up. It's a different picture in Worcestershire. We are much more focused around creative health within public health, and historically have struggled a little bit more with an ICB contact. So it's a very practical question, actually. I just wondered if across the country, do we know what departments within ICBs are generally showing an interest in creative health? I would imagine it differs depending on structures, but I'm interested really to see if there is any variation around that. So any thoughts would be most welcome. Thank you.
I think we found in the Creative Health Associates program that often we were working with population health management teams, transformation teams. We had some allied health professionals. So yeah, that kind of those areas that are looking at systems change and kind of innovative ways of working with the population.
Yeah, that's really helpful. Thanks, Jane.
Sorry, you're in Worcestershire. So what I would say is Ellen Rule used to be my director, was a massive leader for creative health in Gloucestershire.
Mm-hmm.
She now works, she's the chief exec of Herefordshire and Worcestershire NHS Trust.
Oh, okay.
So if I were you, I'd reach
Thank you very much.
I'd reach out to
Hannah.
Ellen.
Yeah, that's great. Thank you.
Really good question, Olivia, though, because I think that is the case for many individuals and organisations. Think about, well, who do I contact? So great answers from Jane and Hannah there. But if others have other particular departments or sections, units within ICBs that they are connecting with, then please do post that in the chat or share your learning and your knowledge. That would be great. I'm going to move us on to Riyadh. Thank you for your question. Over to you.
Thank you, Helen. I'm Riyadh. I'm Assistant Director for Communities and Health Equity for NHS England London. Really good session today. So just looking at kind of London and our metropolitan cities, one of the areas that often kind of comes up in terms of discussions of creative health and how we can improve trust and confidence with our communities is that bearing in mind that many of our communities are underserved. And actually they have vast depositories of culture that are intrinsically not necessarily Eurocentric. It's about how we can kind of facilitate that and bring that into the fore. For example, in London, we had an event in Tower Hamlets, which brought in Bengali culture, music, dance, literature into an event with health fairs and vaccinations and screening, into that kind of mix. And I know that in Birmingham, they did a Spirit of Pakistan event over a week where they kind of blended qawwali and music. But in terms of health, I wasn't sure where that there's certainly something there in terms of arts and culture. So I'm very, very, very keen to look at one size doesn't fit all. Like, for example, my approach, had I lived where my dad is a retired GP in Mansfield, would be different upon how I approach London. And I would apply the same principles of engaging communities in the trusted leaders, trusted voices, trusted places. But in London particularly, we have challenges in terms of building trust and confidence, navigation through health, in terms of Bangladeshi, Pakistani, Somali, and I don't call it Eastern European because that would be a disservice, Bulgarian, Lithuanian, Polish, and Romanian communities, and Roma communities. And again, this will be not dissimilar to Sheffield, Manchester. So there's a bit where we can actually join up nationally and look at the kind of global majority cultures and how we can kind of help almost with the network and collaboration, because many of these communities feel that they're not necessarily equipped, and nor are the VCSE organizations that gravitate their worlds are not equipped to embark in bidding for arts and culture initiatives. So, for example, at the moment, I'm working with 3 organizations in Newham, and I'm hoping through external funding to, based on co-production, based on what they're saying, is actually have some monologues on vaccination and health and well-being through drama. And I was influenced by how Gilead had sponsored the Unseen Voices project in Southwark. But this is actually for the South Asian community, Bangladeshi and Pakistani, through drama. As Bengalis, we call it natok, which is very powerful. And that's where you can get liberal and conservative people in the same room and bring in music in a way that is going to chime with the population through a chai and chat. So that's the kind of thing that we're thinking about. And honestly, I've got the ICB on board, I've got the place teams on board, and I've got the organizations on board, but we need a bit of help to do this, because if we can do it, that would be a great blueprint and encourage others to do more. It's a bit of an appeal, but also something practical, because always you get these kind of people like me saying whinge, 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 but nothing's solution. So I'd like to have a co-produced solution if possible. And I'm very much new in the space, but I have attended some of the creative health events in London because I just feel that we're very much siloed. And in London, it's even more worse, Helen, because we've got 33 villages and four ICS systems, and one ICS potentially will be bigger than Wales. So again, it's about what we can do and in the short term, but also medium to long term. Let's see if we can get this kind of network of kind of community cultures embracing culture and heritage, and what we can do to build trust in health.
Yeah, that's really helpful. Thanks very much for sharing that, Riyadh. Yeah, really helpful. Thank you. And some great examples there of how you've been integrating, public health messaging, prevention with creatives and creative approaches. Hannah, Jane, I don't know if you wanted to have any response to that.
Well, I guess my comment is, like you say, Birmingham are doing some really great work in addressing some of those communities and health inequalities, and I think that's going to be something that I definitely want to capture in one of our next deep dives, making sure we have some understanding of how to engage people through the creative health pathways, and also the mobilising community assets programme. We're doing some in the wider research, so not in the deep dives, but in the research more broadly. There's work, for example, with Roma communities. So I definitely have a look on the website and check out more of the information that's available there.
Okay, which website? Sorry, Jane.
I'll put it into the chat.
Oh, thank you. Cheers.
Yeah, thanks for that, Riyadh. And just to say, we're also in conversation with North London. I don't know how it relates to your ICS actually now. The ICS has changed, but North London ICS. So those guys have been funding small scale kind of creative health projects with some agreed outcomes that they're going to then monitor that data and collect it, and then do the same as basically what Hannah and Felicity and her team have been doing, matching up with business analytics. I don't know if you're in touch with those guys. But maybe we can connect over that as well.
Yeah, definitely. Thank you.
Brilliant. Thank you. Thanks for your question and point. I've got Claire. Lovely to see you. Please ask your question. Thank you.
Hi, lovely to see some of you that I am connected with on LinkedIn, but we've never actually met in person. So there's quite a few of you on the call today. So yeah, for those of you who don't know me, I'm Claire Atherton. I'm the Creative Health and Equity Lead based in Norfolk and Suffolk. My role is part funded by the Culture, Health and Wellbeing Alliance, Suffolk County Council and Suffolk Art Link. I know I've already asked a question, so I'm a bit greedy asking another one, but I'm kind of looking for some advice really in terms of how you've tackled, and you might not have had it in your areas, but how you've tackled the question that often comes my way, which is why are we not looking at Sport England as and the work that they've been doing in terms of within the ICBs and more broadly to the way that they're kind of working, and why are we not doing the same? And I just wondered if you had any advice on how to respond to that question, because I keep coming up against it, that we're being kind of put in the same box, I suppose, when actually the work that we're doing has a completely different remit, I guess. So any advice would be really grateful. Thank you.
It's such a good question and really important point. Thank you.
I don't know the specifics of like what you mean around Sport England. The person who's responsible for physical activity is also in my team, because we do prevention, self-care, voluntary sector. And so we have this organisation called Active Gloucestershire who get funding from Sport England, and then it all filters there. But one of the things that they're great at doing for us is reminding our systems that Arts Council England don't fund us like Sport England do, and that there's a disparity in funding from a national level for physical activity and sport versus arts and culture. And that really helps us because it's coming from the sport people, like the active people, like then sort of commissioners, senior leaders, etc. go, oh really? And it's like, yeah, it's really different. And so I think that really helps us locally because people have tried to liken it to that. But we're just lucky, I suppose, that because we work really closely together, we're able to keep saying it's so different. It's really different. And because also one of the barriers is with regards to the arts in NHS is that the NICE guidelines will recommend physical activity, but won't recommend creativity because they keep saying they need more evidence, and we keep throwing evidence at them. So again, we just keep reminding people of those types of tangibles, I suppose.
I guess my input is I don't know loads about how Sports England run, but we did, when I was a Creative Health Associate, the regional lead for Sports England and the regional lead for Nature England, we met every month and would have conversations about social prescribing as the kind of common denominator between our work. It felt like we did work very differently and the challenges were very different. Like Hannah said, what is available as guidelines of how sport and activity is approached by the NHS and healthcare more broadly feels like it's got more support innately as a thing that they understand, whereas things like nature and art were a bit further. The challenges were bigger. But certainly I would recommend seeing if there are regional people locally that you can have those conversations with, because it was really useful to kind of go, these are the contacts I know, these are the conversations you're having, and see that, because we all kind of are like, well, we're trying to have a holistic approach of non-medical ways of being well and the kind of social determinants of health. So those partnerships were useful, even if we were then having to kind of work separately and differently.
I think that's such an important question, Claire, and a really important point about we're constantly being compared, aren't we, to the kind of more clinical and quantitative data that you can get from, for example, physical activity, which I think is really unfair, and it's also really unhelpful. Something that has come out of both the work with Gloucestershire and the other ICSs that NCCH were doing in the mobilising programme is very much about an understanding of what data means to different people, and having those conversations with, as Hannah talked about, with kind of, the more population healthy people, the epidemiological people, the business analytics people, the kind of data that they work with, and understanding why they need, or why they, the kind of data that they have, I think is really helpful. And ditto then helping to people to understand the challenges of collecting that more quantitative data with a cohort that are engaged in kind of creative arts, nature-based activities, because they often don't understand the challenges and the dynamics that Hannah and Jane articulated really clearly, and that we all know about. Anybody who's implemented standardised health outcomes measures in community creative settings, how challenging that is. So again, that sort of links to these important discussions that we need to have around, what sorts of data and evidence should we be collecting if we want to standardise it, if we want a minimum data set, what is useful for all parties. I think it is such an important question. So thank you for raising that. Marion's got another question. Over to you, Marion.
Hello. Is my microphone on? Yeah. It's a question and response, and it moves from Sports England to heritage, because the worlds that we work with in health and creative health and then heritage sites are exciting opportunities. And I want to go to a creative way. I'm not going to my nerdy measures. I'm a nurse, and nurses aren't on many of the advisory boards. I've just looked at one that's been put up. It's often the medical model or the creative health model. Highnesses of Health is going to happen at Kensington Palace in May. This is showing how queens have helped health, including the Three Queens of Mysore, which was the first public health painting ever, which had 3 Indian princesses changing the way that smallpox was addressed. And this brings together activation scores, vaccine hesitancy, a tour of a palace, which I'm writing, and a way of integrating how health professionals and creative health professionals come to a different place, a heritage place, to value what's gone on, challenge some colonization issues. But this is how we can start to really bring in an activation score. But I need people to help me gather walnuts, because Queen's put the vaccination, the smallpox, into a walnut. And in health, if someone's holding something, it triggers an action. If they then have to put a walnut into a box to say they activated to, health ways, you've got another trigger and a visual trigger. And the actually being embedded in a place can get me some scores on cultural engagement and cultural heritage. But nobody in any ICB or world will go, this is a good idea, because it doesn't fit in any boxes. So my question is, where is the space where, when you're doing something that's so innovative that people just think you're a bit weird, but from a clinical lens, from years, that this is what will engage with community people, can we get some help to make this happen? Where's the radical imagination space that we can start to gather up these a little bit more weird but absolutely effective ways, beyond consortiums and talking about it, please?
Very interesting question. Thank you. I don't know who, Hannah, Jane, who wants to have a go at thoughts on that?
I suppose that's why we were lucky in Gloucestershire for having Simon Ofer, I have to say, who I think is a bit of a radical and a bit of a maverick. And, he was sat in practice, and seeing people, and said, actually, I think you should go and do pottery. And I can't imagine what the first people that he said that to looked at him and thought, so etc. And I get what you're saying about being a nurse, and that on the specialist groups it tends to be the more not that my sister's a nurse, and so I would always put nurses on things first, personally. But so I guess it's about finding people. Just email Simon, maybe. See what he says, is what I'd say. Alex will have his contact details for the APPG and everything. But it's about people, isn't it? Someone needs to take the step, and be able to take that. It's positive risk taking, really, isn't it? We're actually doing a piece of work in Gloucestershire through the Creative Health Consortium, funnily enough, about positive risk taking, and we're going to have a master's through research at the University of Gloucestershire, looking at how clinicians take positive risks, and we're going to link it back to creative health. So there you go. There's something.
I think so often in systems we do see that there's the kind of the big character that is able to push forward so much difference within a system, and sometimes when they move, so does that momentum. And so I guess my reflections are that part of these deep dives is trying to get those systematic enablers to be in place, so that it's not just wholly reliant on a single individual, that something gets embedded, and these are the kind of processes of what's worked elsewhere. But also, I guess it would be worth flagging that NCCH have their Creative Health Leads applications coming up. So they're hoping to embed those advocates into integrated care systems, so that they can take on some of that work of being the voice in the system, whilst having some of that awareness and mindset of a broader integrated way of thinking, community and creative way of thinking. So I think those roles are going to be really important for spreading that across England, really a bit more in a more equitable way. And I think we're quite open to those appearing in different parts of the system based on what locally makes sense for that system. So I'll post the link in there for anyone that might not have come across that already.
Thanks, Jane and Hannah. Marion, I hope that answers your question. And that, again, alluding to the importance of the boundary spanner type people, connector roles, who sit in the middle of that Venn diagram. It's so important to have those roles and those advocates, isn't it, who can help folk like you, Marion, escalate those brilliant ideas and brilliant ways of working and make it more ubiquitous so that everyone and more folk get to engage in it. Any other questions? Please put your hands up, or I know that lots of people are having to go, but very happy to take any more questions if anybody has any other points that they would like to raise. Can't see any more hands. Scrolling through. Look like it. Well, thank you all for taking the time to join us today. I hope that was useful. Lots of brilliant questions and comments and discussion in chat. Huge thank you to Hannah and Jane for sharing your learning, and to all of the team who've been behind the Creative Health Consortium and your colleagues, Hannah, within the ICB, and the rest of the mobilising team for all the work that's gone into this. And like we say, watch this space. Jane and the team and I, we're continuing to do these deep dive explorations at a systems level with different systems. We've got lots on our list, and we're really keen to speak to anybody in those systems and the role that they've played and how we can make them work better. That's effectively what we're all interested in, and learn the great stuff like we have from Gloucestershire. And just to say a huge thank you to Hannah and her colleagues. It's just been such a pleasure and a privilege working with you, and long may it continue. So, as we said, we will be posting this recording eventually on the NCCH website. It gets to get transferred and with some snappy digital stuff, but we'll let you all know, and that will get posted to you, and it'll be available on the website in the next few days. Thanks to everybody for joining us today, and especially to Hannah and Jane and all of our great questions. And enjoy the rest of your afternoon, everybody. Goodbye.